You're at the bedside, your patient is convulsing. Every single second counts, and the call you make right now is going to set a course of treatment that could either save them from years of harm or inflict it. This is, without a doubt, one of the toughest and most critical diagnostic challenges we face. So, how can you be sure? Let's get into the clinical playbook.
So I want you to keep two questions in your mind as we go through this. First, what is the single most powerful physical sign, something you can see with your own eyes, that separates a functional seizure from an epileptic one? And second, what common medication does the brand new first ever guideline from the American Academy of Neurology say we must stop prescribing for these patients? The answers, I promise, will change how you practice.
You know, the reality here has been pretty grim. For far too long, getting a correct diagnosis for functional seizures has been a winding, painful road for patients, often taking an average of 7 years. Just think about that. 7 years of iatrogenic harm, unnecessary and powerful medications, and just profound suffering. Getting this right and getting it right early is absolutely crucial. Okay, so the first thing we have to do is get the language and the framework right. The correct term is functional seizures, and they're a type of functional neurologic disorder. And let's be crystal clear about this. These events are real. They're completely involuntary. This isn't a structural problem or an electrical storm in the brain. It's a disorder of brain function. They are not faked or fabricated. Embracing this is the cornerstone of providing respectful, effective care.
All right, with that framework firmly in place, let's get practical. We're heading back to the bedside to hunt for the clues that tell these two events apart in real time.
An epileptic seizure operates like a hardware short circuit. It is a biological event driven by abnormal, excessive, and synchronous neuronal activity, misfiring physically across the brain. A functional neurologic disorder presenting as a seizure behaves like a software crash. In a functional seizure, the neurological hardware is structurally and electrically intact. Instead, the brain's operating system involuntarily dissociates, typically under intense cognitive or emotional distress.
I want you to put on your detective hat for a moment. Imagine the event is over. The patient is no longer convulsing, but the scene, the clinical environment, is just littered with clues. Your job is to meticulously gather that evidence, to read the signs before that trail goes cold, and piece together exactly what just happened. And here it is, the answer to our first question. If you take away only one thing from this, let it be this: look at the eyes. In a functional seizure, the eyes are almost always forcefully shut. You might even feel active resistance if you try to gently open them. Now contrast that with a generalized epileptic seizure, where the eyes are typically wide open with that classic fixed blank stare. This single sign is, by far, the most reliable bedside clue we have. It's incredibly powerful. But the eyes are just the beginning. A whole story unfolds if you know what to look for. In functional seizures, the movements are often chaotic, asynchronous. Think of side-to-side head shaking or thrashing of the pelvis. They also tend to go on for a long time, often more than 2 or 3 minutes, kind of waxing and waning. And afterwards, the patient often comes back to full alertness really fast, though they might be very emotional. It's a world away from the classic rhythmic, tonic-clonic progression of an epileptic seizure, which is usually short and is followed by a long period of deep confusion and heavy, labored breathing.
The injury profile is also distinct. True lateral tongue biting, lacerating the sides of the tongue, is highly specific to generalized tonic-clonic electrical seizures. Functional events rarely result in severe, uncontrolled self-injury or urinary incontinence. If a tongue bite does occur during a functional event, the injury is almost exclusively localized to the tip of the tongue, rather than the lateral edges.
And here's where modern technology becomes a huge ally. We don't have to rely on just our memory or a witness's description anymore. The new AN guideline now officially endorses using short, 15 to 30-second smartphone videos captured securely by family or staff. Actually seeing the semiology for yourself is a massive advantage, and it's now a guideline-supported diagnostic tool. And that endorsement comes directly from a truly landmark document that is fundamentally changing the standard of care for these patients. This right here is the game changer. For the very first time, we have an official, evidence-based practice guideline from the American Academy of Neurology that's all about functional seizures. This is huge. It takes our approach from the realm of expert opinion to a true national standard of care. And the authors of the guideline just spell out the stakes perfectly. Prompt and accurate diagnosis is essential for avoidance of iatrogenesis. Let's just pause on that word, iatrogenesis. Harm caused by us, by our medical treatments. That's exactly what we're fighting to prevent. So the guideline gives us a really clear roadmap. It tells us, talk to everyone, the patient, the family, any witnesses, use those smartphone videos. It reminds us that video EEG is still the gold standard for definitive diagnosis if there's any doubt. And so importantly,
We must acknowledge a critical clinical caveat. Up to 30% of patients with functional events also have comorbid epilepsy. Diagnosing a functional event does not permanently rule out underlying electrical seizures.
okay, so getting the diagnosis right is step 1. But what you do next, how you communicate and manage it, is just as critical. The guideline actually gives us a script for this tough conversation. Step 1, be direct. Use a clear label like functional seizures. Step 2, explain what it is in simple terms. A software problem, not a hardware problem. It's an issue with the brain's networking functioning. Step 3, and this is absolutely non-negotiable, you must validate their experience.
Say the words, what is happening to you is real. It is not your fault and it is involuntary. And finally, step 4, make the treatment plan together. It has to be a partnership. Clinicians should not, I repeat, should not prescribe anti-seizure medications or benzodiazepines for patients who only have functional seizures. They don't work, they have side effects, and they just reinforce the wrong diagnosis in the patient's mind.
But the guideline doesn't stop there. It's not just about not starting these drugs. It's about actively stopping them. The AAN now officially recommends that we should all be making plans to taper and discontinue anti-seizure medications for any patient with a confirmed diagnosis of functional seizures who does not also have epilepsy. This is a clear mandate to deprescribe. So we've walked through the clues at the bedside, the new guideline, and the management plan. Let's boil this all down into your new clinical playbook. Here are the 3 things I want you to take away today. Number 1, look at the eyes. That forced, resistant eye closure is your single best clue. Number 2, use the video. Tell patients and their families it's okay to capture a short, secure video of an event. It's now a guideline-backed tool. And number 3, deprescribe. Actively follow the new AAN directive to stop and taper off those unnecessary anti-seizure medications. So the next time you're faced with this diagnostic challenge, I want you to remember this phrase: seize the clues, the eyes, the duration, and the recovery. By using these bedside skills and applying the new AAN guideline, you will absolutely improve your diagnostic accuracy, prevent patient harm, and set them on the right path to recovery. Disclaimer and bibliography in the description.